Hello, I'm Liz Brown. I'm the ACNM of Patient Flow at Heart. I basically coordinate the floor, so I'm on the floor every day in the hospital, so it's nice to be here. A little bit of background about our unit. We moved into a new building in 2011, September 2011, so we've just hit 5 years in it. We've got currently 8 operating theatres, PACU, surgical admissions, day surgery, and also the CCSD and acute pain management service come under our Periop umbrella. Briefings and debriefings, we started in our DHB when we moved into our new building, so they've been going for about 5 years now, and I think it was a great time to start. The staff were able to at the time with the debriefings identify issues with the move into the new build, and so it was a really fantastic tool to iron out the kinks with the new building and the processes and the flow. Other benefits that we have found from doing the briefings have been improved teamwork, improved safety, more near misses captured, smoother, quicker procedures, and improved staff morale. When we introduced briefings, the executive in our hospital actually allowed us to shut our theatres down for half a day, and what that did was placed a huge amount of importance on what the hospital thought of briefings and debriefings, and so our entire team went off-site to a workshop. Surgeons, anaesthetists, everybody were invited. So that was really great. We slowly introduced the briefings one theatre at a time and got lots of feedback about how it was going. We focused on having champions in each theatre, and they were great for guiding and supporting the team, so that was kind of a key element for us. We had lots of team communications around how it was going, what was working, what wasn't, what changes were occurring as a result. So a lot of the changes that were occurring we talked to everyone about, so they knew that when they were talking about stuff at the end of the day in the debriefing, that change was happening from that, and that was fantastic. We recently went to paperless. So up until this year we had been using a form where we went through everything on the briefing list and wrote down information, and then that went to the CNM at the end of the day to sign off and identify what needed to be looked at and reviewed closer. When we, in about March, moved to the paperless checklist as part of the Health Quality Safety Commission initiative, we also, at that time, put up posters for start of list briefing and end of list debriefing. And so we've got posters up for both of those, as well as our sign-in, time-out and sign-out. And this has been fantastic. What we do now is when we're doing our end of list debriefing, if there are any issues that need to be resolved, the charge nurse in that specialty or the delegated nurse will write down the issues that then get reviewed by the CNM, so we're not having to fill forms out just for the sake of it. We're only doing it if there's an issue that needs to be reviewed. When we moved to the paperless checklist and the briefings and debriefings being posters on the wall at the same time, we also changed our way of auditing, and we're now using the app that has been created for the Health Quality Safety Commission, and we've actually found that has increased the engagement in the briefings. So we're doing quite a lot of talking to staff at the moment when we're auditing, showing them the app and the graphing that we're getting out of it and what we're looking at, and talking a lot about the engagement. So we've used it as a way to increase the engagement and buy-in from the staff. With it having been 5 years, I think it was quite timely that we're re-looking at what we're doing and how we're doing it, and talking about that level of engagement again. So we have found that has been really fantastic. When we did start, we did have a few issues with people saying, well, they knew what they were doing and they'd spoken to their charge nurse and they knew what was happening, so why did anyone else have to know? But obviously, the more people that know what's going on, the better. Challenges, lessons learnt, what would we change? We have discovered that you can't talk about something once and expect it to be fixed forever. So we are always, as a leadership team, nursing leadership team, talking about how important the briefings are. We're reinforcing messages on a daily basis. So we might be saying, how did your briefing go? Or I observed your team doing a really great briefing, or talking about how important the briefing is. We've also this year moved a little bit towards bribery, and we're giving out lots and lots of chocolate for great briefings, which funnily enough has also increased the level of engagement, because the team comes and says, did we do well enough to get a block of chocolate out of that? So that's been interesting. And champions, we still need to have champions in each theatre to be highlighting the briefings and engaging the wider team. And this is our team, so I just wanted to show them off a little bit because we're very proud of them. I'm going to hand you over to Chris, who's going to talk a bit more from a surgeon's perspective.
Thanks, Liz. And the senior nursing leadership team at HUT's been incredibly active in continuing to promote the whole surgical checklist, and I think it's when Liz talks about champions, she has been the champion. So I am the head of plastics for the Wellington Regional Plastics Unit, but I also work in private practice across public and private in Wellington. So I wanted to just briefly reiterate some of the points, and what I'm going to have to say has already been said. I almost don't need to be here, but I don't apologise for repeating things. I think that just reinforces themes. But one of the problems with an event like today, it's really talking to the converted. And again, what happens is we need to take away skills in how we can proselytise the message, or what I would say lead the surgeons. It's not always about surgical leadership and putting surgeons in the leadership role, but leading them into a position where they're able to lead or participate in their team. So, as we've heard, HUT was an early adopter of briefing. I think, and just these are my views, and I'm by no means the best briefer or debriefer. I've got colleagues who are superb, but so just bear that in mind. I've got colleagues who are appalling as well. But from my point of view, it's logical. It's a no-brainer that you want to start off your day with a plan which is coherent, with a single focus for the team, which is working through the day. So from my point of view, I just don't see why it should be an issue. And the issue often for surgeons is they don't like change in culture, and they feel like if people are telling them to do something different, it must be because they're being criticised for doing something wrong to begin with. It promotes the smooth running of a list, it's about patient safety, and it's just an extension of the planning system. So in my department, I plan my list. There's a theatre planning meeting, which is then discussed, and this is just an extension. So it shouldn't be identifying anything new at that stage, but it always does. It promotes professional cohesion, it promotes respect, and it promotes social cohesion. So I'm not quite sure about the issues about why it's not being adopted, but there are some issues. Briefing is just part of a system. Each part of the surgical checklist reinforces the other, and this is part of a system. Team consistency, I think, is often stronger predictor of safety. So if you have a team that is consistent and you built up relationships, perhaps that takes a big burden away from the need to have a briefing in terms of introduction of staff to an environment where they may not be familiar. So that's something really important. I disagree with Ian on a couple of things. You've got to be pragmatic versus rigid in the application of these things. And so do we insist on the whole team, or do we insist on a part? And sometimes we've done the briefing without you, can you comment on these things? And we've got to be flexible and realise there are times that you can't have a whole team. We've got to work out that culture change in theatre is exceedingly important, but in HUT we've got this big pressure to put knife to skin at 8:15. And we found that earlier starting is impacting on the ward nursing handover because it's now being interrupted by surgeons wanting to see their patients. So that key point of hospital safety is being impacted upon by a time to improve hospital safety in another area. We've got to be aware of that. We've got to be consistent. Wellington, here we go, we've got 45 theatres in this area, 25 or so in public, 20 in private. And there's a real inconsistency about how people apply briefing across those theatres. Last week I was in 5 theatres in different DHBs and it was applied in very different ways. Now, is that good or is that bad? I think it's good being flexible, but it does lead to confusion with staff who may pass between different theatres, so you've got to be aware of that. Very quickly, briefing I think is well established. It allows us to reflect on positive and negative issues. It allows identification of issues to strike while the iron's hot, while you remember it, and looking at both intrinsic, what happened within the theatre, but how did things outside the theatre impact on your day. You can't forget that, that's really important. It's a really good time to address any conflict, and it's a fantastic time to say thank you, and I totally agree with that. That is the fundamental purpose of briefing and something I've used a form of debriefing for years. But it all too often looks only at the negatives. Strength is as a positive agent for quality improvement, so you look for good things to build upon, not just bad things. And at the end of debriefing, staff may be utterly inconsistent. So if I've done a 16-hour case, the teams in theatre may be entirely different apart from me. Hopefully, some people, so you've got to be aware of getting the message to the people that count. And at the end of lists, which is almost when everyone debriefs, the anaesthetic team has taken the patient away. So the anaesthetic team is absent. So I entirely think the best time for a debrief is after final check for the final patient, and then you do your debrief. And issues and concerns must be acted on. There's an issue which has been raised in my debriefing in my theatre for 3 weeks. No comment from management, no action, and already surgeons going, what's the point? What's the point of bringing this up if nothing's going to happen? And so it must have buy-in. So there was a letter from Ian trying to encourage surgeons to come, and so these are just some comments from surgeons about why sometimes, it's another talk fest. I thought we'd finished with all that. There's the message, and these are the true comments by colleagues. I can't do it, my manager's on my back, my volume's behind, I can't give up another session. The half-day workshop was brilliant. It was really good. There's another half-day workshop. The first hour was good, but God, what a waste of time. So we've got to think about how we get the message in a way that's being able to be accepted by surgeons, and that is about surgical leadership. And I think the key thing with surgical leadership in trying to get surgeons to adopt this is modelling, and we've heard about modelling and walking the talk. I like that. That was really good. I'm repeating some of these things. And surgeons need to have reinforcement and explanation of things. So recently I did the Lex Operate with Respect online module for the college, and it was fantastic. 45 minutes. It's a carrot and stick approach. So the carrot is you get CME points. The stick is you don't get credentialed. And I think it's a really good way to proselytise a message. One of the issues with a lot of messages that come out of Health Quality Workshop Commission is it's really heavily aimed at the DHB sector. 50% of surgical discharges in the city come from the private sector, and very often they're quick adopters. And if you can tie practice, good best practice, to where the surgeons are credentialed easily, they will bring that practice from one sector back to another. And this is my debriefing on Monday in private and my debriefing on Tuesday, and they're both at the time when the anaesthetic team is still in theatre, so you can talk about the issues raised with the whole team.
Afternoon, everyone. I'm Craig Skidmore. I'm an obstetric and gynaecology consultant based in Hawke's Bay, and we have, for over a year now, in general throughout all our theatres, been debriefing and having a morning brief. And I think rather than a purposeful direction, I think it was almost an unexpected consequence perhaps of another process, which was increasing theatre productivity, and it was the concept of being there on time in the morning and ensuring that the whole team is there. It's a bit of an experiment with some of these slides, so I might have to push the button several times. So what I thought I'd talk about briefly is really the history of the team brief, purpose, the content, improved safety and examples, and a bit of a summary. And again, this is somewhat repetitive but hopefully useful. I guess by the 1800s we'd sort of worked out how to stop bleeding and knew that pain and infection were important in theatre. However, surgery was by no means safe, and there were very poor outcomes for a great number, and surgery should then have been regarded really as the last option rather than a preference. A couple of hundred years have drifted on, and internationally for this millennium, certainly the recognition that safety concerns and some real attention to some of the subtler aspects of surgical care warrant a lot of attention. The estimates range, but 0.5% to 5% of hospital admissions have an element of error in care, and that's reported. Half of the errors in some studies have been seen to be related to surgical procedures, and of those, researchers suggested that half of those are, would be deemed preventable. So there's a clear incentive to improve. It's just the World Health Organisation's initial surgical safety checklist. A couple of pics from our theatre. I'm sure you guys will probably also have illustrated posters up on your time in, time out. Team brief in Hawke's Bay. A couple of years ago we started trialling that through ENT and ophthalmology, and others joined in. The general rollout around 2015, and we were piloting that in the context of theatre productivity improvement, as I mentioned. That there was a strict time for starting, was strongly encouraged. All team members were expected to be present, and we certainly still continue to quite strongly encourage everyone to be there whenever possible. Occasionally, if a surgeon is not immediately present, they may nominate their registrar or someone else to present for them. We define, pretty much in line with Health Quality Safety Commissioner's guidelines, several factors that might influence our safety and coincidentally our efficiency and our operation times and turnaround. And really this, the patient and safety factors, as mentioned, perhaps for a bit of an unexpected consequence. There's a very elaborate wall sticker or laminated sheet where and this probably hails back to when we were trying to start on time and promptly. We're incentivised to be able to circle the yes with the removable marker. The true purpose, though, has morphed, and I think is quite in line with the goals of this project, and that the cases are planned. Exceptional cases and equipment needs are identified. Where there may be tight surgical sterilising turnarounds, we sometimes will reorder or adjust what we're doing. And I've found some other aspects from a personal point of view. Simply knowing when theatre staff are available until really does help when an unanticipated delay in a case ensues, typically requiring a lot of attention to that case for methodological or operative purposes. The last thing you want to be doing is working out, can you do the next one? And I think we will feel that pressure from time to time. So actually knowing that people are simply not available after a certain time does often simplify it. And I know that's very simple, but it's quite helpful. Just a little take on making sure the right equipment, so the right things are there. This would be a major bugbear, as we talked about earlier, with the orthopaedic surgeons and their prostheses. I just had a little bit of a look at some of the research and recognised that interpersonal conflicts amongst the surgical team, as has been noted earlier, is a major factor, and the majority of accidents in technical professions have human error as causal elements. More importantly, a lot of these errors do involve interpersonal or relationship issues, both in leadership and conflict, leading to flawed decision making, etc. And when interviewed or questioned about this, the operating room staff and professionals did identify that communication problems are an overwhelming barrier to operating room performance. The problem's a constant theme within healthcare and can disrupt safety and efficiency. So the content of the team briefing has been well discussed, and better than I'll do it. Introductions, list and case specifics, anticipating case issues. Staff changes throughout the list has been discussed as well, but it's important, and finish time. And really what this, if you can see my red circles around there, it does preempt at the beginning of the day quite a number of the surgical safety checklists, which is appropriate for each case. I've mentioned expected end time and anticipated delays, and I think training is also an important aspect, and we have several teams who are wanting to train. We'll have junior nursing staff scrubbing for some selected cases and they need the time to learn. We'll have anaesthetic trainees wanting to gain appropriate experience with patients, and we'll have surgical trainees. And discussing that at the start of the day I actually find very valuable in apportioning the right time in the cases to balance carefully service delivery with learning opportunities. And a couple of examples of where the briefs have assisted us: knowing the 5:30 finish time, and the surgeon, for example, the team can continue their attention on the case in hand and deliver a better anticipated plan. Noting that there are four sets of equipment for 5 cases, and being able to space out or adjust the setup for one case prior to starting. Discussion with the anaesthetic team is often conducive, or clearly it's conducive, but it's also very helpful when planning the full day, and often gives people the opportunity for an anticipated break. Probably does relieve the pressure off the anaesthetist who's about to ensue on a tricky case. We sort of see these as minor benefits, but all contributing. And I've mentioned timing for training. So in summary, it encourages, I think, in our unit, the right atmosphere for teamwork, and people, no matter what their role or responsibility level in the theatre, are empowered to speak up when they foresee an issue or when they suspect there is a problem. Opportunity really exists to identify issues before anaesthetic induction for the cases. It plans for the entire day, and I think helps for overall planning. So very supportive of it, and thank you for the time.